art, and I think what we all are doing to our patients in a way is art too. Repairing the repaired, astigmatism management in keratoplasty. I have no financial interest in any of the products that are to be mentioned. Okay, so as ophthalmologists, we should be all proud that the first solid organ to be transplanted was the cornea back in the early beginning of the 20th century. And very early, ophthalmologists back there thought of lamellar, what we know now, lamellar kind of transplantation. This guy, Edward Conrad Zerm, is the one who first implanted the first ever cornea. طبعا 50 years later يلا الكدني transplant صار 1954. anterior lamellar بدأ 1914 ب 56 endothelium. And along this long history, there were a lot of kinds, types, improvements to the procedure until it reached the procedure that we know today. It is classically said that 90% of those patients, of those procedures are successful procedures. And by success or successful, we mean a clear graft, simply clear graft. Now, maintaining clear graft was regarded as a successful procedure. In the era of refractive surgery, cataract refractive surgery, demanding patients, I don't think this is going to be acceptable anymore. Optical performance of the graft is maybe the thing that governs the success of the surgery. The average post-keratoplasty astigmatism ranges from 4 to 8, and we all have seen much higher astigmatism. Factors contributing to this astigmatism is a long list of factors. Everything, you and the patient, instrumentation, everything you can put on the list, and it's going to be true. The management, to simplify things, we can classify it into pre-op, intra-op, and post-op. For the pre-op, actually I don't have much to say. You just plan the size, you prepare the logistics. I don't have much to say. That's why أنا خليت صورة هذا القوري to fill the emptiness. واضح إنه كان قوري كلش مهم. Intra-op. One of the things that matters is the graft diameter. Graft diameter above 8.75 is labeled as large graft diameters, and it does actually decrease the astigmatism, but this should be weighed against the chance of rejection. Chance of rejection, as you all know, is higher with larger diameter grafts. Between 7 to 8.5, actually there's no difference. Anywhere between 7 and 8.5, there's no difference regarding the astigmatism post-op. Below 7, definitely higher incidence of astigmatism, especially the irregular one. Okay, so trephination, a tilt in trephination as small as 20 degrees. You know, 20 degrees is very small. 20 degrees is just like this. 20 degrees will cause 0.5 millimeter of tissue disparity, and this tissue disparity is actually a major cause of astigmatism. The shorter graft from one side will leave us, the tissue deficiency from one side will leave us with a steep axis and vice versa. Scleral support ring are used classically with aphakic eyes and vitrectomized eye to support. Those very supporting rings might be the cause of distortion of the globe. Suture techniques may be one of the controllable factors that will gravely affect the results. Tools like marking and per-op keratoscope are valuable tools to end up with fairly regular cornea. A lot of techniques described in the literature interrupted, running, double running, mixture of both. And if you just search for the comparison, you'll find hundreds, if not thousands, of papers comparing all these procedures, those techniques, suturing techniques. And the actual conclusion, you end up that maybe the best way to go is a mixture of between interrupted and continuous running. But again, it's a matter of preference, if I may say, for the surgeon. The one thing that is agreed upon is that the cardinal sutures are the most important, and the second one at the 6 o'clock is the most important one in regard to astigmatism prediction. Okay. The post-op factors. Well, for the post-op way to manage astigmatism, first we have to agree on what basis we are going to follow up our patients. Is it refraction? Is it keratometry? Is it topography? Well, I must say that topography today is a must to follow up your patient. Anyhow, refraction to be taken into consideration, of course, because you don't want to correct corneal astigmatism that is compensated by lenticular astigmatism. Refraction is important, but the most sensitive, I would say, way of following up a patient with keratoplasty is a topographer. In the absence of a topographer, well, you can rely on refraction plus keratometry. Astigmatism tolerability. Do we need to correct any astigmatism? Well, tolerability differs according to so many factors: the age, the occupation, degree of anisometropia, binocularity, etc., etc. Some patients are very demanding even with a 1 diopter, and you all know that. And some patients can tolerate up to 5-6 diopters of astigmatism. But it is generally accepted that 3.5 is the tolerable amount of astigmatism. Now, suture adjustment and removal. This is the primary factor affecting the early post-op period, affecting the astigmatism production and management. For the running sutures, you can adjust as early as 2 to 4 weeks, no more than 2 months. For the selective early interrupted single suture can be removed in 2 months, المتساهلين, or 2 or 3 months. You can remove your first interrupted. If you are using only interrupted, you can remove your first interrupted suture from the steep axis, of course, and you are allowed to remove one every month or 6 weeks, بشرط ما يكونون adjacent. Okay? Then, for the combined, continuous and interrupted, actually you can remove your first stitch in a matter of 2 weeks. Well, if we reach an acceptable residual astigmatism, we can go on with spectacles, RGP, hard contact lenses as well. If not, we're going to go for further surgeries. Okay. Further surgeries in general are needed in 8 to 20%. Almost 1/5 of keratoplasty patients might need, between 8 to 20% might need another procedure, another surgical procedure. There are a lot of them. We have laxing incisions, laser vision correction, intracorneal rings, toric IOLs, and wedge section. I'll talk a few words about each of them. Of course, when we say we need a further, this does not mean that this includes the elderly people who cannot manage putting contact lens, has rheumatoid arthritis, of course, dry eye and intolerance to contact lens, or even a patient with leftover with 3 diopters of cylinder that he or she wants to get rid of her glasses, this is included in this category. Okay, so surgical intervention, this is an important point. Surgical intervention should be delayed. Well, أكثر المتساهلين يقولون 2 months after the last suture to be removed. Some authors advise 6 months after the last suture to be removed before planning for a new procedure, so that things settle down, the corneal shape takes its final shape after this grave surgery. Relaxing incisions to start with is something else, differs from relaxing incisions that we know. Very nicely, Dr. Najah presented yesterday relaxing incisions and opposite the clear cornea relaxing incisions for the normal corneas. In post-penetrating keratoplasty, this is another story. We all know that maximum correction may be, for example, maximum correction in a normal cornea, 3 diopters, 5 diopters, 3 to 3.5 diopters. Here, some papers published up to 15 diopters of correction in just relaxing incisions that might be augmented with compression sutures. Okay, the nomogram differs. Nomogram differs totally. There, in a normal cornea, you can enhance the effect by increasing the length of the incision, the depth, the proximity toward the center. Some age is a factor as well. Here, we only have the amount of astigmatism that governs the whole thing. Placement, they can be placed in the host donor junction, in the graft donor host junction, graft host junction, or inside the graft. Outside is actually useless because the scar that is formed is, as we all know, is the new limbus. Beyond it, you cannot correct anything. And of course, they should be put on the steep axis. Length between 45 to 90 degrees. Those are the publications, and it is fixed no matter the. You have to fix your incision no matter the amount of astigmatism you are correcting. Depth 70 to 80. To enhance, of course, you'd put compression sutures. Femtosecond laser, of course, is another way, not only mechanical, is another way to perform relaxing incisions. The other option is laser vision correction. The best candidates, of course, those who have good best corrected vision and with low to moderate refractive error. Whether the same rules apply. The same rules for other any laser vision correction procedure, the topography rules, etc. Whether to use LASIK or surface ablation, this is a matter of debate. Actually, both of them have some lower astigmatism correction predictability. They are less predictable, and this is quite expected. For the LASIK part, it is said that the flap will never return to its original place, and some papers suggest that the procedure should be done in 2 separate sessions, 2-3 months apart. Just create the flap, put it back, go back 2-3 months to correct the astigmatism. This may enhance predictability. The minimum time for a microkeratom to cut through a graft cornea is 12 to 17 months. Femtosecond laser for flap creation or SMILE, and nowadays we have papers talking about SMILE in a graft in keratoplastic corneas, might be helpful. And we know previously transplanted cornea produce more haze. We are talking about PRK here, producing more haze, and of course, the higher the degree, the more haze you can get. Okay, laser vision correction has another advantage, is that the potential for correcting irregular astigmatism. And we will be talking about irregular astigmatism every now and then. It's beyond the scope of this talk, but irregular astigmatism in those people can be corrected first by contact lens, hard contact lenses. Another way هو laser vision correction, customized ablation. And a third, maybe the intracorneal ring. This is a third way to correct, to some extent, and predictably, the high order aberrations. Intracorneal ring segments can be helpful in regular and irregular astigmatism after PKP. The candidates with poor best corrected vision, those people with poor best corrected vision, with high astigmatism, and good vision potential by RGP or pinhole. So the patient can be corrected with RGP or pinhole. We can go for rings. Okay. Ring should be implanted inside the graft. No graft-host interface interaction. You cannot interact with these junctions so that you can avoid induction of rejection or so. Can decrease the irregular astigmatism. I don't know if you can see the rings here, and there. This steep cornea. This is a short video showing that. Mechanical versus both have advantages and disadvantages. Mechanical is more like tough on the graft cornea. The femtosecond has the drawback of the suction and compromisation of the graft. The other way to correct the astigmatism after keratoplasty is the phakic toric IOLs. And we know that we have them available in our market, the ICL, the Artisan. By the way, Artisan has higher cylinder range, up to 7.5. And I prefer it, actually. So it's a little bit tricky. The ICL calculation, length of the ICL correction calculation is a bit tricky in keratoconus patients that I've observed. A lot of them having higher volt. Maybe I was preferring the Artisan for more predictable results. Patients with cataract, of course, there's toric IOLs. Toric IOLs have very high range, reaching up to, I've implanted myself a 14 diopter cylinder, and there's more you can customize. You can ask the company to, I think up to 18 or something like that, diopter of a cylinder. Wedge resection should be left for the very high astigmatism. Limber relaxing incisions or stigmatic relaxing incisions are to be tried before going to wedge resection. Wedge resection should be left for the very high astigmatism, just like I'm going to show you right now. It's basically removal of a wedge. The base of it is on the surface of the cornea, and the depth reaching almost 90% of the cornea thickness at the interface, and the piece of tissue to be removed is from the donor side. It can correct up to 25. Actually, there's one paper published correcting 28 diopters of cylinder. It has its coupling effect, just like the relaxing incisions. This is a case of extremely high post-PKP astigmatism for a young lady who had keratoconus, cross-link. Then she did her keratoplasty abroad. Look at the refraction of the left eye. 7 diopters that actually do not represent the actual astigmatism. The basic complaint that she came from, that she had headache all the time. She has headache. And the topo, as you can see, it shows 23.24 diopters of astigmatism. It's a huge amount of astigmatism. Then we decided to do her wedge resection, and is done in August 2016. I'm gonna. For the nomogram in wedge resection, there are several nomograms. Basically, you get 1 to 2 diopter correction for each 0.1 millimeter removal, tissue removed from the cornea. And the length varies between 60 degrees to 60 to 90 degrees. Of course, the longer, the higher correction you get. And after removal of the tissue, you suture very tightly and you aim for overcorrection. Overcorrecting the astigmatism can be compensated temporarily by an opposite compression sutures. Sutures to be removed in 6 months, and you remove them selectively starting at 6 months. It's more or less just like a new graft. It has high morbidity, so that we can left this option for the very high astigmatism. This is the piece of tissue that you are going to remove. And I'll skip the rest of the video for the sake of time. It's just suturing. I'm just going to show you. I want to show you the gap. It's a big gap, and it is advisable to penetrate actually to get soft eye for tight suturing. And what happened here inadvertently was a rupture. It was a penetration. So this is. It seemed huge, but this what really the patient needs. So see the gap is big. Okay, we'll go. For the results, and the results, as you can see, this OS has now minus 4.5 at the same axis, and the lady sees 6/12 in a 14. This result in 14 months, and this is her topography after 14 months of follow-up. You can see down there the astigmatism go down to 6. I don't know if it is clear or not. 6.4. And they have a slide comparing both. This is down. This is the pre-op. This is post-op, and you can see here 23 something reaching to 6 something diopter of astigmatism. 14 months apart. And thank you very much for your attention.
Thank you, Dr. Sohaib.